Okay, طيب, I would like to thank you all. It's too late. Also, I would like to thank the committee for changing my lecture many times. So, about thoracic trauma. What is thoracic trauma? So, my objective in this lecture, just I know it is a course for preparing you for exam and preparing you for a real exam as a real patient, really. So, try to enjoy this lecture and you'll find good stuff inshallah بإذن الله. طيب, so by the end of this interactive discussion you'll be able to apply ABCD. I think my colleague Dr. Basim went through this principle. I will repeat it again. Also recognize the important life-threatening injury in a patient with thoracic trauma. Finally, evaluate the case scenario of patient with thoracic trauma to identify immediate life-threatening injury. To be honest with you, this lecture I give this lecture for many times really. I give this lecture for MCH Maternity Hospital in Mecca, and also for many people, and I think they have a good response for this lecture. So I'll make it real for you. The most organ is mostly common injured in real life, in any trauma for adult, for pediatric, for geriatric. It's all about thoracic injury. Why? It is white space. Also, it is in the center of the body. So remember, once you have head injury, think about thoracic injury. If you have a pelvic or lung bone, think about thoracic injury also. So starting from the anatomy, what is the anatomy? It is, if you know the anatomy, you will identify the injury and type of injury, and also how to manage it. First, I would like to be organized every time. If I ask you what organ in the thoracic, remember, go from away or from out to inside. So don't forget about the skin. Skin is the wide, larger organ in the body. Skin, subcutaneous, ribs, and also you will find both lung, heart, and great vessels. This is not all of the organ in the chest. Don't forget, there is a trachea, part of trachea. Also, there is esophagus, and finally, forget about diaphragm. Diaphragm, we are missing. I know. Sometime if I open laparotomy, every time I'm missing about, forget about the diaphragm. So my second question, this is important question really. This is what we are like to find in any patient, in a real patient, in a medical case, I know, and also in trauma patient. This is what I'm looking for it. If I have this case with this finding clear, crystal clear, I will discharge the patient direct. But the question now, how you can read X-rays? I know it is like intern or medical student question, but really, even for the consultant level, you should be organized to deal with chest X-ray first. Okay, it is important tool, important investigation in thoracic injury. So there's many tools, many ways. I know each of you in this level he had his way, but for me, if no one has this way, I think this module, what I'm going to tell you now, I think this is the best module. So remember to imagine the chest like circular, okay? Going from up, circle the lung, and going back, okay? So what's it mean? This is mean, just check for the first one, the trachea. Is it centralized or not, okay? Is there any tube or not, okay? Then look for the mediastinum. Mediastinum, is it wide? Is it centralized or shifting to the right or left? Then to the cardiac shadow, okay? Sometimes if you are lucky and the patient is thin, you can see gas around heart, okay? Also, if you're going down, you will find what we call diaphragm, okay? This is diaphragm is now as I mentioned, we are always forget about that. In X-ray, you should remember it, okay? Also, if you are looking for the diaphragm, don't forget about hemothorax because you will find alteration of the postophrenic angle here. So going from up, heart, diaphragm, and going up again. Going up again, just remember to check for pneumothorax, okay? Both type, minimum, simple pneumothorax, okay? Or massive or tension pneumothorax, okay? Then we are going back to the center, so check for the ribs, okay? So 1, 2, 3, check all until down, okay? Is there any fracture or not? Is it done? No. Don't forget about extra outside skin. Check the skin for surgical emphysema, check for scapula, and check for clavicle. I hope it will be add value for you. So I like to give a scenario. It's I think it's kind of it will be fun. Okay. So if I say to you, we have a 10-year-old child. Okay, involved in high speed. He was in the back seat and he had a seat belt also. They ask you, we are far away from 5 minutes from the hospital. What you should do? I believe many of you they are not having many cases of the trauma. So to be like, okay, what should I do? What should you do? Just remember, the magic word. It is A, B, C, D, E. Okay. So prepare yourself for airway. What you want in the airway? You need oxygen mask. You need tracheal tube. You need a tracheostomy tube. In breathing, what you want? You need a chest tube. You need pleural vac. Okay. In circulation, I need two line, large caliber line. After that, what you need in the C circulation, I need two large caliber. Okay, I need blood to be ready, FFP platelet, class common score. What you need? I think nothing, just your otoscope and lights. Okay, and finally exposure. You need a blanket. So preparation for receiving the patient. Okay, so once the patient in your hospital, what you should do. So if I say to you, just remember, he's a 17-year-old male involved in high speed with blood pressure is 90, heart rate is 125, and respiratory rate is 40. Is it stable patient or not? To be honest with you, at the beginning, remember, we are not both stable, unstable, the same system is going, ABC. So, but in this case, he is unstable. So still, we are going for ABC. A, it's airway. What should we do in airway? Just open the mouth, check the mouth for any foreign body. Put oxygen mask. In A, don't forget to check two things, important thing. This is important also in the exam. Check the trachea, is it centralized or not? And why after you are checking the trachea, is it shifting to right or left? Apply the neck collar. Always don't forget about neck collar. Breathing. In breathing, this kind of examination, what should we do in the examination? Also, B, it's like a medical student exam. Don't forget, this is where you can find a lot of degree and you can pass the exam also, even real or your exam in pediatric board. So by inspection, palpation, percussion, auscultation. Inspection is both like is just moving symmetrical. Is there any decreased movement in one side? Is there any paradoxical movement like also is there any surgical emphysema by palpation? Auscultation, is there a decreased air entry in one side or not? Also don't forget about check for heart, is it muffled heart sound or not? And finally, palpate for surgical emphysema and for any tenderness and rib fracture. So inspection, palpation, percussion, auscultation. If you answer those questions with checking the trachea, you will find you identify the pathology. So first question also always, this patient is kind of unstable. Blood pressure is 90 over 50, heart rate is 125, respiratory is 40. I know there is also, to be honest with you, there is a difficulty even for me as a trauma surgeon when I dealing with the pediatric. Is heart rate 125 is normal or abnormal? So it is changed depending on the age of the pediatric. But 125 for 10 years. Sorry, 10, I have a mistake here. It is a 10 year. So it is, yes, it is a tachycardia and he's unstable. So what life-threatening you are thinking? Okay. And what is the next step in evaluation? I mentioned A, B, C, D, E. Okay. So what we need to answer? The answer is in A, B, C, D. So the final patient complained of profound short of breath. Oxygen saturation is 89%. He had a cervical colon brace. As I mentioned, it's important thing, trachea deviated to the left and breathing sound absent on the right. So it is opposite side. Decrease absent sign, absent sound on the right, and trachea is deviated to the left. Heart rate is sound is normal. So what you are thinking about here? What is going on? Unstable patient with absent right chest sound, right breathing sound, and trachea deviated to the left side. So if you have any answer, so I will answer this. What is the potential most likely? To answer, you should differentiate. You should. I missed one information here, important information for me. We said about inspection, palpation, percussion, auscultation. So if I missed one examination, I will not have the answer. So in this situation, I need percussion. Percussion, it was hyperresonant the right side. So I think I make it easy for you. Once, so it is kind of pneumothorax, okay? Because it is decreased breathing sound on the right and deviation on the left trachea to the left side of the trachea. But the question now, is it attention or simple pneumothorax? To say it attention, it is not meaning it is a pressure. Attention is a clinical. It is not an image identification. It is a clinical finding. How I say it's attention pneumothorax if the patient unstable. So in this scenario, patient heart rate is, I will go back, sorry, 125, blood pressure is 90 over 50. So it is always, it should be like unstable patient. So we should think about potential pneumothorax here. Can be a hemothorax, sorry, in this case. Yes, if the percussion was dull. So it is meaning there is a fluid in the right side. After 2 slides, I will go for differentiate between hemo and pneumothorax. What is appropriate technique to manage this patient condition? So the management always. If anyone you ask you about the management in trauma patient, don't forget Yes, I know. Everyone will say, okay, tension pneumothorax, I will go for an immediate decompression. Yes, correct. But you missed a lot. There is a lot you missed out of mark, really. You go for ABC. A, you need oxygen mask, full oxygenation in 100%, keep the color, and so on. Breathing, circulation, attached to large caliber line, withdraw blood for cross-matching, platelet, and FFP to be ready. So it is the management. Unless he said, okay, what is a therapeutic management for this patient? Yes. Now, therapeutic management is what we call is needed decompression. So I'll go back for this. So in this case scenario, needed decompression was performed and there was a rush of air. So vital signs improved. My question now, I didn't see any X-ray until now. Do we need X-ray from the beginning, from once we receive him in emergency or not? To be honest with you, it is a lot of mistake. It is not a mistake really, but I know sometimes it's challenging to put a needed decompression and you ask yourself, is it a tension? Is it a symbol? Can the needle hit a major organ and cause a bleeding? At that time, this is a risk and benefit. Always I said for my resident, the risk, if you are waiting for X-ray, the patient he can be collapsed at any time because it's a tension. So by this, I think the decision should be managed and X-ray after. And no one blame you if you hit artery or something and cause bleeding because the management is like this. Unfortunately, if you have an X-ray and the patient collapse after that, yes, now it will be like shame really. So in this case, we know no need for X-ray. So where we should apply the needed decompression? This is a question. So where should we apply? I know many of you they will say second intercostal space. Unfortunately, this no. This is in the fifth intercostal space. This is an adult, but also in the pediatric, still we can put it in the second intercostal. Okay, what alternative management strategy can you use here? Any idea? So I know sometimes you can say, okay, needed decompression. Where should I put in the fifth intercostal space, in the second intercostal space? Sometimes for some surgeon, they said, okay, I'm so fast in one procedure and I can do a maneuver and apply chest tube directly. This is yes, we can apply it to what we call it as a finger thoracotomy. This is just like, okay, put your finger inside the pleura, rupture the pleura, and apply the chest tube after. Because once you apply, it is a simple procedure really. Incision skin, put your finger direct, push hardly, and evacuate the gush of air. So after that, gush of air went through, and what is the next step in the management? Is it finished? No, we need to apply a chest tube. So after you applying a chest tube, does the job is finished? No. Always remember, there is a missed something. There is something should be done. After needed decompression of thoracotomy, we need to apply a chest tube. After that, what should we do? So what we are missing to do a X-ray, chest X-ray. Why we need the chest X-ray? In the next scenario, we'll see why we need chest X-ray. Just to be sure about the position of your chest tube. Is it in good place or not? Is it kinked? Is the hole is outside or inside the chest? Okay. So what is the question now? What is the difference in clinical presentation between tension pneumothorax, open pneumothorax, and pneumothorax? So I'll make it easy. Tension pneumothorax, tension. The word tension is unstable patient. So the difference between pneumothorax, tension, and open pneumothorax is only the word of tension, unstable patient. Pneumothorax is same. You will find decreased air entry on the right side, per se, and percussion to be hyperresonant. If you differentiate between hemothorax, it will be decreased air entry also in the hemothorax on the same side and dullness on the same side. What about the heart sound? Heart sound can be muffled in both cases, in pneumothorax and hemothorax. With the situation of busy emergency, everyone shouting, baby crying, it will be difficult to assess the heart. So this is the image by someone. He identified tension pneumothorax and he did X-ray. What is the finding here? Why we call tension? Tension is like a pressure, yes, but he is unstable clinically and vitally. So tension is huge air trap inside the lung and it push everything away from the center. You can see here, this is air, this is a lung, okay, it's collapsed totally. Also the heart is pushing to the other side, okay, and trachea is sorry, it is not clear image, but this is the best I'll get really. So it is by this way, it is tension. Why we call tension? Tension because it is compression of the heart. So the heart is no preload going to the lung and no afterload. So it will like a stone in its side and it's not working, it's not pumping. So patient become unstable, tachycardia, hypotensive. So what is different in management? Open pneumothorax and pneumothorax, simple pneumothorax. So We have tension pneumothorax, we have simple pneumothorax, and open pneumothorax. It's same management, but I would give you a question. The question is always they will ask. Even my resident, they are asking me, what is the management? The management is always ABC, as I mentioned. But here, should we apply chest tube first, or we apply this three-side occlusive dressing? Why we give before? Why we name it as three-sided? Because what we are making as a valve. Okay, we cover three sides and keep one open. This open for the air is while the air in inspiration going outside, and while the inspiration is closed and work as a valve. So my question now, should we apply three-side occlusive dressing first, or we should apply chest tube? Same the question, which comes first, chicken or the egg? But the answer is clear really for me. Apply chest tube first, then apply your three-side occlusive. Why? Because sometimes three-side occlusive dressing it changed to four-side occlusive dressing. So it will be closed here by itself, by something we don't know, and it will be work as trapping air inside. At that time, that it can be changed if it is like air leak from trachea or something. It will be compressed hard and cause attention if there is any other way to the air to go away. So apply chest tube first. Remember always apply chest tube first. The patient he will not die from open pneumothorax. He had another lung, but unfortunately, if the three-side occlusive dressing changed to four-side change, four-side occlusive dressing. Okay, another scenario: 9-year-old involved in high-speed front and back motor vehicle accident. Vital signs is heart rate, respiratory rate is 20, heart rate is 160, blood pressure is 60/50. So same, how should we prepare ourselves, how we should manage, and how we identify the injury. 9 years look like as unstable patient for me. So it's always ABC. We should assess the airway, breathing, circulation, disability, and glaucoma score, and expose the patient. So the answer for me, oxygen saturation 98, CPAP collar in place, trachea is not deviated, excellent. The breathing sound decrease on the right side, heart sound now normal. So again, what important exam is missing here? For the chest, we go for inspection. We are missing here. Patient missing. Auscultation, yes, it's decreased on the right side. But I would like to know about percussion. What type of percussion there? Is it hypervision or dullness? In this case, it's dullness. Okay, so yes, so this is a vital. This dullness will decrease air entry. So how we can manage this patient? Always remember ABC. If the patient had hyperresonance, I'll go for management before. But the patient he's having a dullness and the management is ABC, and we need to secure secure the airway for him and secure blood to be ready for him. In this time, we can wait for the X-ray to be done. If I show you this X-ray, what's the finding? The same. Remember, circular, how to read the X-ray in the circular method. So, trachea is centralized. Mid times I cannot assess. Diaphragm, I am losing the diaphragm here, shadowing, and losing of costophrenic angle. Also, I can see the shadow here. Look like the line shadow here, and the color is different here. So it is. For me, it's dullness, decrease entry on the right side. So the finding it should be like hemothorax. Can be a hemothorax change to tension hemothorax? Yes. If it is massive and compression and cause the patient is stable and push everything to other side. So in this case, what is the management? Okay. Always, if I say management, remember A, B, C, D, E, airway, breathing, circulation, disability, and exposure. So the important thing in management in this kind of patient, we can lose this patient so fast. Why? Because they are bleeding internally in the thoracic cavity. So we need to secure the blood weight and secure blood to be ready and FFP and platelets. As I mentioned, there's obscure right diaphragm and also with pulmonary contusion. So the management here is we need to secure two large bore IV line and starting IV fluid and type and cross match to be requested as we mentioned. Yes, this is what we call as pleural evac. This is just to collect the blood while we are putting the chest tube, and we can collect the blood and we can use it again after that. So, thoracotomy tube, this and 600 dark blood drained. Okay, so we identify now to differentiate between pneumothorax, hemothorax, tension pneumothorax, and massive hemothorax. So, if I say to you, this patient, he had 600 blood once I applied the chest tube, is there any indication for surgery for him? And when should we take a decision for surgery? I know if you don't know the indication, so it will be kind of difficult for you to take a decision, even for the thoracic surgery sometimes. So what is indication in a massive hemothorax? So I find something important here for the indication. In adult, if it is the amount of blood at the insertion, it's about 1.5 liter in the first insertion or in the first hour. So it is an indication for a thoracotomy. Why? Because there's a massive bleeding. But sometimes you cannot reach this volume in 1 hour. You need about 4 or 5 hours. So it is difficult to calculate. But if it is 200 in each 2 hour or 3 hour, so it is a massive. You should consider thoracotomy. In the pediatric, because depending on the age, because the blood volume is different from pediatric and adult. So in pediatric, it is more than 20 in first hour per kg, sorry. And if it is more than 3 cc per kg in hour over next 2 to 4 hours. Okay. What restrictive measurement should be undertaken in a patient with a massive hemothorax before thinking about thoracotomy and everything? Remember, this is a blood, and I mentioned for my resident, we should not fade from blood. I know you are a pediatric surgeon and you are dealing with pediatric, and you are having a strong heart really. If you are dealing, for me, I cannot deal with a pediatric age really sometimes, but I think you can deal with the blood. So what is the management here in a hemothorax? Remember, it is only blood transfusion. Remember, it's a blood transfusion, secure the way for blood, okay, as you see here. So we finish pneumothorax, tension pneumothorax, open pneumothorax. So after you apply a chest tube and stabilize the patient, everyone happy, and what should you do in the secondary survey? So secondary survey is head to toe, but I'm talking especially for the in the chest. What should you do? Remember, the chest is as usual. It is a inspection, palpation, percussion, auscultation, and forget about and remember about adjunct. Adjunct in the chest is oxygen saturation, and also remember to do X-ray, chest X-ray. Why we need chest X-ray? As I mentioned before, many reasons. So this is the X-ray for one patient. He had a hemothorax, and they applied chest tube, but unfortunately, the patient is still unstable, and the chest tube is there is a leak all the time. Can anyone find what is the reason in this image? Yes, we will go again. Trach is centralized. Sorry, I think opening is out. Yes, correct. يعطيني وقت الله يعطيك العافية. ما شاء الله عليك عبد الرحمن. يس ما شاء الله. طيب opening is out. طيب خليني أقول بس يعني the trach is centralized. Tracheostomy. والله ما أعرف أنت why you are calling as I. This is I أول مرة أسمعه بصراحة. This is I called as opening. It's good يعني good name صراحة. طيب so it is the trach is centralized. Mediastinum is centralized. The wing of the heart is good for me. Diaphragm, yes, okay. And we are going back, check the ribs, okay. No fracture, nothing. But still, there is something. There is a surgical emphysema you can't see. Here is much clear, but here there is some fog, some air here trapped. So remember, once you check the tube, you should check the position, is it kink or not, and check the eye. Okay, so this is the opening. How you know where is the opening? The chest tube, there is already opaque material. It's white. You can follow until you have a cut point. Cut point, it should be all the tube. Be sure. Some tube there is a two opening. It should be inside. Okay. So this is outside. So the patient he will become unstable. There will be a leak, and will be develop a surgical emphysema all over the chest, and sometimes it's extended to the face. So in secondary survey, in the chest check, inspection, palpation, percussion, auscultation, and don't forget about chest X-ray. Okay. So after that, the patient becomes stable. We talk about simple pneumothorax. Now I'll go fast with some disease. It is important to know, and it is easy to treat really. Like flail chest. Yes, I know. It is catastrophic if you find some patient he had a flail chest. What is a flail chest? A flail chest is, by definition, it is a fracture in two consecutive ribs in both sides. What is the problem here? The problem is paradoxical movement of the chest wall. سبحان الله يعني ربنا خلقنا تمام chest wall is moving in one piece, but if it is moving two way, one is out, the other inside, the physiology is be matter. Okay, what is the pathology in flail chest? It is not related for a paradoxical movement. This is about the underlying lung injury, because you have something broke about three ribs in both sides. You should think about the underlying tissue. If you have seen a lung before, it is like sponge really. So it should be there's a contusion, massive contusion. Sometimes the rib is hitting lung and cause bleeding. I saw in my life 4 cases, part of the ribs is inside the lung, and that mandate to go R and pull the rib away. Okay, try to think about the heart. It might be a cardiac confusion. So what is the management here? Okay, how you can diagnosis a clinical inspection, palpation, percussion, auscultation. So the management here, management. Remember, if you want to pass the exam, remember ABC. You will pass the exam, inshallah, within that. So airway, breathing, circulation. But there is specific thing in management in the plate chest. If I say, is it a beta blocker, massive fluid resuscitation? Is it immediate nebulizer treatment or supplemental oxygen, pain control, and recognize potential for respiratory failure? This is, I think it is easy question, but I would like to keep it like this. It is choose letter D. We need to supply oxygen. Yes, D. Good. So we need to supply oxygen and good pain management. I remember one of my colleague, his ophthalmology. He was riding motorcycle and the motorcycle fall down in his chest. He spent about 2 days. He's athletic, mashallah, tabarakallah, and he spent 2 days having a pain until he came to me and showed me his chest. I saw huge contusion. I said, what happened? He said, the motorcycle is overlapping on me. So we did X-ray. We find multiple fracture with one contusion. So the management is, and he had a severe pain and he cannot tolerate. So the problem here, the pain, it will cause the problem. What problem if you have a pain in your chest? You cannot take a deep breath. You cannot respire very well. So we need to control your pain to let you have a good respiration just to clear your lung. Okay, because if you have pain in your lung and a lot of secretion will be accumulate in your lung, it will be complicated by atelectasis and respiratory failure, pneumonia. This is the type of complication. And also, don't be generous in treating by fluid. You should have a good control of fluid resuscitation, because the lung, it will be like it is a sponge. If you give a lot of fluid in not working lung, it will be accumulated there and it will be causing massive lung confusion and edema sometimes. So plate chest pulmonary contusion, we talk. Okay, it is blunt cardiac injury. It's kind of fun, really. So if we talk about cardiac injury, what type of cardiac injury we have? I know everyone will say, okay, we have a cardiac tamponade, but we have also a cardiac contusion. So what is a pericardiac tamponade? How we can identify pericardiac tamponade or cardiac tamponade, sorry, by examination, inspection, palpation, percussion, auscultation. The finding is unstable patient with muffled heart sound with distended neck pain. If you find these three findings, you should identify cardiac tamponade. Okay, why we have unstable patient cardiac tamponade? Because the air or fluid is trapping inside the pericardium and this prevents the heart to pump. It's like a tension pneumothorax once you push the heart to other side. What is the management? Management, always remember ABC. I forgot to show. This is the heart and this is the fluid here. It's like a free fluid in the heart. What type of management we should do? Really, it is two types of management. One, this is for non-trauma surgeon, and the other is for trauma surgeon. For non-trauma surgeon, what we call it as a pericardial synthesis, we will go for wide caliber syringe. It is like a spinal syringe and direct it from the sternum to the nipple and go in 45 degree, easy and slowly. And you should have put the patient on monitor. Why on monitor? Because you need know once your needle attached to the heart, because once it's attached to the heart, you will find arrhythmia. I mean that once you have arrhythmia, you should go back. So once you hit the heart, it will be arrhythmia, and you need to withdraw blood. This is a question. It's fun also sometimes. Is this blood coming from the chamber, or it is from the pericardium? How we can differentiate? Any idea? It is kind of difficult sometimes, but there is a maneuver. You can once you draw blood and try to evacuate in a bottle and just see if it is clotted. If it's clotted by time, it is from the chamber. If it is not clotted, so means it is a pericardial fluid or blood. So if clot blood means it is from the heart, from the chamber. If it's not clot, so it is from the pericardium. Why it is not clotting from the pericardium? Because in the pericardium there is a fluid, and the fluid is caused like a dilution of the effect of the coagulation factor. So once you put the fluid attached to the blood, all the fluid is not activate the cascade, and this prevent no fibrin, and it is not activated. So this is one type of management. There is another type, which is for the cardiac, for the cardiac and for trauma surgeon, what we call pericardial window. We have a small opening below the sternum, opening easy like if any one of you did, sorry, I forget the name, small opening, sorry, anyone?
You were asking about something from the panelists. I'm sorry, you can go on.
No, anything, if anything, anyone want to interrupt me at any time, really.
Okay,
So,
you can go on, Doctor. Thank you.
yes, thank you. So we can what we are doing in the port side, the first port side, just open at the side of the sternum, going cut the skin, a fat, and until you reach the pericardium. By that, you can take a snip and open that and suction it. As a trauma surgeon and cardiac surgeon, we are doing this, not usually, but in a special case, really. Now, yes, before I forget, so we have in the heart, we have two type of injury. One is cardiac tamponade, and second one is a cardiac contusion. So there is a contusion in the heart. How you can identify a confused heart? I know some of you will say fast echo something. Really confused heart, it will be act as confused. Yeah, and if you have confusion in your muscle, you will jump all the time. Okay, from the pain. Also, this is from the heart. Just remember, once you have confusion in the heart, it will shout like how he will act. He will act as arrhythmia. Yes, thank you, Muhammad. So this is arrhythmia. So many of my residents, they ask me, Dr. Meshal, you have multiple refraction, a central site, and the ER, they are calling me for, we should admit the case as a case cardiac tamponade. When we should admit the patient for cardiac contusion, or how we can differentiate or identify the cardiac contusion. This is two things to be done in any patient if you suspect a cardiac contusion. One simple thing, ECG. If you have arrhythmia, it's in. You should admit the patient. You have a cardiac contusion, fixed triad into monad. Yes, it is a fixed triad into monad, but in cardiac contusion, so in confused heart, it is like the heart act as MI. Yes, ECG, good. And one thing, I'll make it. I don't know. I keep the chat open really. Yes, enzyme. What kind of enzyme? Second beta troponin. How many times? Q8, Q12 hour. Just for observation. So if you have cardiac contusion with ECG change, admit the case. Follow the enzymes. Okay. Next day you need to do echo for him. Yes, thank you. Okay. How many minutes remaining for me?
We will stop the discussion. We will start the discussion at 9:45.
At 9:45. So it is.
It's now 9:37. We still have about 10 minutes.
Yes. Okay. Good. In good time now. Thank you. So this is what you call yes. We talk about simple pneumothorax, flash chest, blunt cardiac injury, and cardiac tamponade. We have traumatic aortic disruption. It is a rare injury. Because why traumatic aortic disruption? Because the aorta is behind organ. It's saved by the ribs, saved by the heart, saved by the lung. So you will find it. Why we have this kind of injury? Because acceleration injury. Okay, the injuries can be found in ligamental arteriosus of the aortic, and the management is how you can identify this finding. How you can identify you have aortic disruption. So this aortic disruption is like this. This is the aorta, and this is an injured in the aorta, like doing like as aneurysm here. So dissection is loss of aortic knot. This is the aortic knot, and you cannot find this. Sometimes you will have hemothorax. Okay. Sometimes the radiology they said yes, there is reactionary fluid in the lung with this finding. Remember, any fluid in the trauma patient is hemothorax until proven otherwise. So if you have, this is an important question, should we apply a hemothorax, should we apply a chest tube in hemothorax with suspicious of aortic injury? The answer is no. Don't apply a chest tube unless the patient is unstable. Okay. If the patient is stable, we have hemothorax, don't apply the chest tube because this fluid, this blood is keeping the tamponade at that side. Yes, thank you, Mick Tamponade. Thank you, Muhammad. So, what is the management? Management is if you have the facility, always remember to ABC the patient and keep the blood pressure low. Because if you have patient hypertension or increased blood pressure, it will cause to rupture this aortic dissection. And finally, refer the patient for intervention and radiology. MashaAllah, intervention and radiology solve a lot of problems for all specialty, even trauma now. I will go back here. Yes, this is one of my case. Not here, صراحة. He's a lucky one. He's old age. My question now, when we are going to do a thoracotomy in any patient, I know there's a thoracotomy for massive pneumothorax, as we said. hypertensive permission. I think you are talking about cardiac, sorry, aortic dissection. It should be hypotensive. Keep him to the lowest blood pressure. So what is indication for thoracotomy? Thoracotomy is two indication. One, if it is you have a massive pneumothorax and unstable patient. Unstable patient is not meaning you need to do a thoracotomy for a blood. You would like to clamp the aorta for perfuse the heart and perfuse the lung. In this case, I remember this patient, he was having intra-abdominal bleeding, but we go for thoracotomy, not because of a hemothorax, because we need to perfuse the lung and heart. He's a fortunate guy, and I think he had also stabbing from the flank and hit the stomach, hit the small bowel, and also hit the aorta. So this indication for thoracotomy, as we mentioned, it just depends on the amount of the fluid. Okay, just I have finally just two last slides. This is about insertion of the chest X-ray, so chest tube, how you can apply it. I hope this is a clear sound. I will stop every time. So I will go from the beginning. So it is what he's doing now. He's doing a finger thoracotomy, potency incision, open the skin and push hard. So he just identified, he's functioning now. Yes, you can see. Second, is it finished now? Yes, he's open wide. Yes. See, he's putting his finger again. Yeah, I'm sure he's inside. Okay, even here, maybe he hit the lung, no worry. But why he's put his finger again? He's doing this maneuver just to be sure to release any adhesion between the lung and the posterior chest wall. Why? Because if he didn't do that and there was adhesion, he will hit the lung and cause more injury. So this is what happened now. He's checking right, left, and he's putting down. See? Yes, and leave it inside. To be honest with you, I like to this maneuver. Don't use the guide wire, the big one, because it will be hard to the lung if it is puncture the lung. Okay, I think that's all from my side. I would like to thank you all for giving me this opportunity, and I'm looking for any questions now.
Thank you very much, Doctor, for this outstanding lecture. We really enjoyed every single detail. We have a couple of questions from our attendees. The first question is from an anonymous attendee. He's stating, what is the safest way to do pedicardiocentesis?
Okay, to be honest with you, there is no safe way. You are hitting the heart. Sorry for that. But yes, this is depends on the maneuver. A maneuver, it's clear by the book. It is a large caliber needle hitting 45 degrees from the xiphoid sternum, directed to the nipples, okay, or the left shoulder, and go easy, step by step. You should remember, you need to put the patient on monitor and keep your eye to the patient and the monitor. Once you hit blood, you have backflow for the blood, watch screen. If there is any arrhythmia, go back and continue suction the blood. I think this is if you do everything, even if you hit the coronary artery, I think no one going to blame, because just all the condition is direct to patient unstable, hypotensive, muffled heart sound with descending neck vein. So all going with the pericardial for cardiac pneumonia, and you need to do pericardiocentesis. And if you need to do everything 45 degree direct to the nipple, keep the patient monitor, observe for arrhythmia. So what's next? No one blame you.
Another question from Dr. Inas. Where do you place a chest tube in an open pneumothorax? At the same level or above it?
To be honest with you, sometimes I stuck with the book. The book is said fourth to fifth intercostal space until the mid-axillary line. But I would challenge you, and I will give you the question. If there is an opening on the same side, in the fourth intercostal space, at the same side of the your injury, what you are going to do? Are you going to apply from the same opening, or you will go another way? I think I can receive answer in the chat or something. Okay.
Yes, Doctor, you can.
anyone.
كانت
I'm enjoying يعني بصراحة هي this type of lecture أنا سألت organizer is it interactive or just lecturing؟ قالوا ما شاء الله عددكم 200 وهذا، فكانوا خايفين انكم يفتحوا المجال يعني to be horrible today بصراحة. Yes, محمد مهند والصافينة another. I totally agree with you. Now, why? Any reason why? No answer. So we prefer to go for another incision because it is what we call kind of wound. It is being contaminated now, and your procedure of the chest tube should be clean. Why? Yes, wound is dirty. Yes, excellent. So it is the wound is dirty. One, if you for two reasons. One, it is a clean, contaminated or dirty wound. Sorry, and the chest tube should be clean. Why? To to avoid the embayema. This is right, totally agree. Because if you put it through the wound, it will be dirty chest tube and will be stuck in the chest and it cause infection and embayema. And it's just a horrible complication really. And you would go for bath, for drainage, or a lot of things, for antibiotics. But by this way, go. If it is in the same fourth, go for the fifth. If it is in fourth, you can go up. If it is in fourth and fifth, you can go for third. Sometimes I found someone going for second across the space. Okay, yes, it is difficult. Don't go for the second because there is a risk for axillary artery injury. But go down, fourth, five. It is below. Remember, if you go below fifth, it is a risk to go for through the diaphragm and hit liver or spleen. I find in my life I have two cases, one in Saudi Arabia and one in Canada. To be honest, it was horrible. They hit the liver and caused liver injury, and we took the patient to OR. Not because also they are hitting the bowel. It can be happening anywhere.
Also, there's a question from an attendee. What are the indications of emergency room thoracotomy in the present day?
Yeah, as I mentioned, two reasons. One, it is for massive hemothorax. If you have massive hemothorax in the emergency and the patient unstable, always say emergency thoracotomy is a difficult decision, but the patient he is pushing you to do this thoracotomy. The most important thing is arrest patient. Okay, unstable arrest patient, or he's going to arrest. Okay, so if you have arrest patient. There is an indication in any thoracotomy. So I will keep it easy for you. This is the reason for arrest. Is it a bleeding from the lung or it is a bleeding from other way? If it is a bleeding from the lung, it's clear. You can do a thoracotomy and finish. But sometimes if the bleeding from the abdomen and you need a thoracotomy to give a blood supply to the brain and the heart, and you need to do a thoracotomy, there is another indication, another parameter you should consider. Like how many minutes he had arrest this patient. Is it 10 minutes? What type of injury? Is it a blunt trauma or penetrating trauma? So if it is a penetrating trauma, this is in this case the patient pushing me to do a thoracotomy. If it is about this than 10-minute arrest, okay. If it is a blunt trauma and more than 10 minutes, so it is no hope. So no need for thoracotomy. So I will summarize: three causes: massive hemothorax, okay, and or patient unstable or arrest, and the bleedings from other source. So you need to go for thoracotomy if you have unstable patient and you would like to secure the blood supply. I hope it's clear.
It's clear, Doc. There's another question from Dr. Muddathir also asking, what is your recommended fluid management in severe lung contusion?
Okay, what is the management of fluid? Choose any kind of fluid, but don't give him like 1 or 2 liters. Even for the stable patient, remember, I don't like fluid. I know you're just trauma surgeon, but I don't like the fluid. The fluid is the challenge is give him what he needs, don't go beyond. Now it's changed in Italy, it's not 2 liters, now it's 1 liter only. The best transfusion or the best fluid to steady the patient is blood. This is not meaning all the patient give blood, but if you indicate you need to give a patient fluid, give him small amount, this amount of fluid, if he's stable, and if he's not stable, consider to give him blood earlier.
Excellent. An anonymous attendee is asking, Doctor, in the video of the chest tube, the sutures were applied before. Can you tell us about this technique, please?
To be honest with you, I don't know. يعني I don't know why he applied chest tube before. أنا شفته بصراحة أنت بتكلم بس I don't know this technique. To be honest with you يعني ما راح أسوي نفسي أفهم كل شيء بصراحة.
Allah يعطيك العافية, Doctor. Another anonymous attendee is asking, can we do pericardiocentesis ultrasound guided?
Yes, it is. If you are expert in ultrasound and you can do it, do it. I like ultrasound. I like to play with the ultrasound machine in my calls and even in emergency. And even if I go to the emergency for any case, just try to take ultrasound and identify. It is many time you'll be expert.
Excellent.
I will add one thing also. Nowadays, just Google it, okay? We are using what we call a big tail in chest tube. This big tail, it can be used, it is a small big tail. It is like what we are using in the abdomen, but it's very, very, very tiny, small. We are using in two indication. This big tail, it can use in one, in the pneumothorax. If you have a pneumothorax, I would like to suck the air, okay? And you don't want to leave a big scar for the patient. And the second, if you have pleural effusion, it is a clear fluid. It is not a blood. It will not clot and will not block the drain. In this scenario, in the big tail, there is two ways to apply: blind, like guide wire and that, and also another way it is by ultrasound. So ultrasound you can use everywhere, really.
Excellently, Doc. And the last question, which is a little open-ended questions, what is your recommendation about esophageal perforation management?
Sorry again.
Esophageal perforation management, Doc.
Yeah. So esophageal management. I didn't put about esophageal, but we can talk about esophageal injury. It is one of the catastrophic injury, really. Starting from the diagnosis. Diagnosis, it's not in the same day, not the second day. Sometimes it's delayed to the fourth, fifth day. But there is finding in the CT or X-ray. You should consider it if you have what you call surgical emphysema and resolving chest tube or air leak, and you find a pneumomediastinum, air in the mediastinum. So just consider there's maybe a suspicious of esophageal injury. If you have it, you should diagnose it. If you suspect, do a diagnosis diagnose by using water-soluble contrast, not gastrographin. If you didn't find any leak or injury, now you should use gastrographin. It is a double agent, a double contrast. First of water soluble, second by gastrographin. If you have the injury, so it is you should manage. Management is about of thoracic injury, but sometimes as trauma we have finding in the stabbing in the neck. But so the management is depend on the patient condition, stable or not. Second, depend on the side, is it anterior, posterior, and depend on the size of injury, and is there any ischemia in the lumen or not. But the management is three parts: primary repair if you can. Second, put a graft or like a muscle, and the third is drainage. Okay, so it's three parts. One, primary repair if you can. Second, apply graft like a muscle or omohyoid or anything. What you can put as a graft, you can put it. And finally, a drain. Put a good drain. If you cannot close injury, you can put it like a tube, like put a esophageostomy, like opening through the neck, or apply multiple drain. Sorry, with the gastrostomy or genostomy. Yes, if we are continuing about management, you should consider feeding tube in this case, because he will spend long time without MBO.
Excellent, doctor. Very clear. We thank you again for this great lecture. We understood a lot and we learned even more. And also on behalf of the attendee, you answered all their questions. So thank you again.
Welcome. Thank you very much. Thank you for you. Thank you for the committee. Okay, and that's it. Thank you very much.
Thank you very much, Doc, and hope to see you again soon.
Yeah.